Assalamu alaikum. Today we are here again with the topic of ACS, and we will tell you about the ACS, the pathophysiology of the ACS, the high risk feature of the ACS, and actually ACS encompasses all like STEMI, non-STEMI, and unstable angina. So we will cover here the non-STEMI and the unstable angina, the risk stratification and the risk stratifying scores, and then the treatment and the strategies how to treat the non-ST ACS. So I think without wasting time, we need to start over here about ACS. Okay, first of all, I will, sorry, I was a bit hungry, that's why I'm eating the dry fruit. So sorry. First of all, we will do the pathophysiology. I will tell you about the pathophysiology of the ACS, and then we will move towards the approach, how to approach the ACS. So that is the same things which occur actually in non-ST ACS. Okay, so what is this? This is the same plaque, actually unstable plaque in non-ST ACS. Okay, and the non-ST ACS actually encompasses two things: the non-ST elevation MI and unstable angina. Okay, unstable angina. So the morphology and the characteristics of the plaque is actually unstable. That's why we encompasses this non-ST elevation MI as a non-ST elevation ACS. Okay, so what are the characteristics of this unstable plaque? That the capsule of this plaque is actually thin, as it was in ST elevation MI. So what happens here, if this thin capsule ruptures anywhere from here or here or here or here, it causes what? Again, the activation of the platelet system, the clotting system, where the platelets comes here and the GB, 2B3 causes morphological changes in the platelet, and the thrombus formation actually starts. What happens actually when this disruption, which actually causes three things, causes three things, the erosion and dissection causes what? This rupture of the plaque, capsule of the plaque, which is actually thin in the unstable plaque. So then second step would be here, like the thrombus formation, and then after thrombus formation there would be a vasospasm. So these three things could be together in the non-ST elevation MI, and it could be alone, like only erosion and the disease, only thrombus formation because of the any procoagulant state, and the only vasospasm in the presmental angina. So if this disruption causes infarction in the heart, it would be non-ST elevation MI. If this disruption occurs but this myocardial infarction yet to be done, okay, so it would be unstable angina. The only difference and the only borderline between the non-ST elevation MI and the unstable angina is the infarction of the myocardium, which actually rises as the TROPS, the leakage of the biomarkers. So the additional features, the additional things which we would have in our patient with biomarkers, we conclude it and we diagnose it as a non-ST elevation MI. But if you get all the things of the non-ST ACS but not this, it means myocardial infarction yet to be done. Okay, so you will call it as a unstable angina. But you have to be very vigilant in these patients, because anytime they could be turned into non-ST elevation MI or might as a ST elevation MI. Okay, so because this is, and one thing more, in ST elevation MI there would be a complete occlusion of the artery because of this thrombus, but in non-ST elevation MI there would not be the complete occlusion but the partial occlusion. Only the partial occlusion of the artery causes what? Infarction. So this is actually the pathophysiology behind what? Behind your non-ST elevation MI. Okay. So yeah, I am eating together here and drinking green tea. Actually, I am fond of green tea. You can join with me if you can come here. So the utmost thing, because you know that cardiovascular system is most notorious. Cardiovascular serious diseases are actually most notorious for the sudden cardiac death in all over the world, and in those ischemia is obviously the worst one. So the neglected and the missed portion of the ischemia is actually non-ST elevation MI after the posterior wall MI. So how to approach the ACS patient, because ACS encompasses all the patients who are actually coming in ER with chest pain. Okay, so up now that ACS would be probable, suspected or definite, but these all would be ACS in the ER. But these patients who are actually coming to you in the ER, in which the most of the time 70% cases would be non-cardiac, only 30% would be cardiac. But in 30% now you have to rule out that are they ischemic, non-ischemic, STEMI. If they are ischemic, then STEMI, non-STEMI or unstable angina. So it's actually an stable angina, because most of the time you are dealing in the ER the patient with the stable like symptoms. Okay, so the stable angina. So the how to approach the patients who are actually coming with the ACS in the ER is the important thing for us. Okay, so what would we do here, that if the patient you have coming with the chest pain is actually ACS for you, now you have to take the history and all these things, then you will rule out. Okay, first of all you should know about the chest pain. Okay, what is a typical chest pain, atypical chest pain and non-cardiac. So the typical chest pain is the chest pain who has actually 3 points. What are those 3 points? One is typical in nature, like substernal, okay, above the umbilical, below the chin, above the umbilical, below the chin, you will give the 1 point to it, and this pain would increase with exertion. So again you will give it at 2 points, and if it would decrease or intensity decreases with multiple sublingual nitrates or with the nitrates, it means so that would be the third point. Okay, if your patient has all these 3 characteristics of the chest pain, then most of the time your patient is complaining of the typical chest pain. But if on any of 2, like these 2 or these 2 are like your patient is presenting with these 2 types of the characteristic of the chest pain, then your patient has probably atypical chest pain. But any of one, if your patient is complaining about the chest pain with any of one of these characteristics, that probably your patient has non-cardiac chest pain. But here the important thing is that the non-cardiac chest pain is not mandatory to be non-cardiac, especially in the diabetic patient and high risk patient and the elderly patient. So for this you again need to memorize and remember what the pretest probability. What is the pretest probability? I think I should write here pretest probability. It is very important. The only important thing about it is that if the middle age man, like 40 to 49 and 50 to 59, is coming to you with non-cardiac symptoms, again it would be intermediate in nature. His or her his pain would be in intermediate risk of nature. But if the same age of female is coming to you, then the risk of this patient to develop the ischemic heart disease is low. So age is again a very good risk stratifying factor here, and the gender as well. Okay, but what you need to do, that you will take the history obviously, then you will check for the high risk features in the history. You will start from the history. He will tell you the age, obviously with the age and gender and symptoms. These three things will tell you about the nature of the heart disease and the probability of the heart disease with the pretest probability which I have told you earlier. So obviously if the age is elderly, like more than 60 years, and the patient is female, this patient would be intermediate. So you can't discharge this patient. You have to keep this patient and you need to do the monitoring of the patient obviously. Okay, so high risk features are age, gender if it is male, okay, and the symptoms. The most important thing is that if this patient has a typical symptoms like the typical chest pain, atypical chest pain, or non-cardiac chest pain. So you need to intermingle all the interpretation with the symptom. If the symptoms are non-cardiac but the age is more than 60 and gender is male, then obviously this patient would be intermediate to high risk. Then you need to keep the patient. So it is very important to gather the knowledge with history. So number one thing we have here is history. So the patient who is actually coming to you in the ER, you need to take the one is history, and you in history the high risk features are obviously age, gender and symptoms. Second thing, what are the high risk feature in the symptom? More than 2 episodes of chest pain, more than 20 minutes of chest pain, okay, and the chest pain is increasing in nature, like crescendo type of the chest pain, and that chest pain is actually new onset, like less than 2 months. So you don't have to do anything for this patient, because this patient already comes in the definition of unstable angina. Got it? For this patient you do not have to do anything, because this patient already comes into unstable angina. You need to take this patient. Now you will apply the risk scoring system for this patient. So see how much history is actually important for your non-ST-ACS, for your ACS patient. Okay, now come to the second thing. What would you do? That high risk clinical exam. You will rule out the other things like the perichondritis, pneumonia, and all these non-cardiac symptoms. Okay, or if he or she has a cardiac history of like Marfan or sort of things, then you obviously you rule out the aortic dissection, or you will rule out the type of the chest pain. If this is more of like ischemic in nature or non-ischemic in nature, okay, then you will come to the obviously examination. What you will do in the examination, obviously you need to check the pulse. If the pulse is more than 100, BP, blood pressure is less than 90, obviously this patient is something going wrong. Then you will check the chest. If this patient is in the pulmonary edema, if you are appreciating the S3 gallop, and if you are appreciating any murmur of MR, so obviously this patient is sliding towards ischemic heart disease, sliding towards ACS. You cannot discharge this patient with all these things, or you cannot send this patient outside from the ER. Now, any other more things? On exam, after exam, then you obviously will send what? Investigations. What you will appreciate on the examination is ECG. If you are getting ECG on more than 0.5 mm ST depressions with AVR elevations, so obviously it shows what? Multivessel disease or left main. Again this patient becomes what? High risk. Then you cannot send this patient. So it is very actually easy if you go systematically, if you go from head to toe. Okay, then after this you will obviously you can do the TROPS as well. After ECG you will go for the blood test. If the blood test TROP is coming positive, obviously there are certain indication to send the drops, which drop you are actually sending. We have discussed it that high sensitivity or conventional drops, so you will send obviously drops accordingly. Okay, after sending drop, you will check the response of the drop. Is it increasing in pattern or decreasing in pattern? Again, it would tell you about what? It would tell you the seriousness of the disease, the seriousness of the plaque. If drop is in like increasing in more than 2 or 3 times, 5 times or 6 times, so obviously Gusto 2B trial told us that if your patient with the non-ST ACS has the high troponins, okay, very high troponins, then it tells what? It tells 3 things, that on angiography probably you will find 3 things. One is a multivessel disease, left main, or thrombus at the plaque site. These 3 things actually causes what? Raised troponins, highly raised troponins. So if you are getting the highly raised troponin in your patients, it means probably you will get what? You will see the multivessel disease on LSC, left main, and the thrombus at the site of the plaque rupture, at the culprit rupture plaque. Okay, so these things are actually high risk for your patient. Obviously, if your patient has all these things, then obviously you will apply what? Then you will do the risk stratification of the patient, which is actually very much important. Risk stratification of the patient is very much important. We have discussed all the things, the chest pain or all these things. I think there's no need to repeat again and again all these things. So we rush towards what? At our risk stratification. So here you have a 2 risk stratification system. One is a TIMI, which is actually very important, and this TIMI actually came from TIMI 2B, okay, TIMI 2B and Essence trial. These are the 2 trials in which actually TIMI was used. Okay, so TIMI TIMI score for the risk stratification of the non-ST elevation MI patients has come from where? From the TIMI 2B trial and this Essence trial. Is actually important to remind all these things, because you know the data and the references of your tools. Second thing is the GRACE score. So TIMI of non-ST elevation MI and the ST elevation MI is actually different. Because the risk factors and these 2 disease and their process are actually different. That's why, and the treatment is also different. So this TIMI of non-ST is obviously different than the TIMI of ST elevation MI. Second thing is we have so one is TIMI and second is GRACE score. Got it? GRACE score. So this GRACE score is same for all ACS. GRACE is same for what? For STEMI, for non-STEMI, and for unstable angina. Got it? So as I told you, there is only one difference between the unstable angina and the non-ST elevation MI is that you will get the leak drop in non-ST elevation MI. Otherwise, the treatment and all these things are same for the unstable angina as well as for non-STEMI. So GRACE score. So these 2 things actually help us to treat our patients. So it is very important to risk stratify your patients from the first medical contact in the triage. Then you will go obviously move here. If you will find the typical chest pain, age and all these things, obviously then your patient will be definitive ACS. But if you are not finding anything but the age and only risk factor, then this would be probable. But if you are getting 2 or more things but not the definitive any investigation or any evidence to say it as a non-ST elevation MI, then this will be suspected. But anytime probable would be definitive and suspected would be definitive. So you have to do ECG monitoring, serial drops, serial ECGs, okay, to look the changes in the ECGs, and if you are getting the dynamic changes of the ECGs, it means this patient has a ongoing ischemia, because that is the only thing which actually gives you what dynamic changes, because any other disease or any other like morbidity with the heart cannot give you the dynamic changes in the ECG. So here now you have diagnosed your patient with, now you have ACS, and you have to distribute your patient and risk stratify your patients into 4 groups. One is very high risk, high, intermediate, and low. So accordingly you will do the strategies, and you will apply and you will treat your patients accordingly, because ACS is a big term actually. You cannot send all the patients in the cath lab for the left heart cath, okay? So you need to risk stratify the patient, which patient actually deserves left heart cath, because you are like receiving and like you are seeing a lot of patients, like thousands of patients in your cardiac emergency. You cannot send all of them. You need to rule out them, you need to risk stratify them into certain groups. So the high risk group, very high risk group is are actually ongoing ischemia, ongoing chest pain, refractory to medical treatment, refractory to medical treatment. If you are giving again and again nitrates and your patient is again and again complaining for the chest pain, obviously then these patients are actually high risk. So your high risk patient should go actually for the immediate invasive within 3 hours, okay, within 3 hours, not like primary within 19 minutes, but for 3 hours, okay. And for high risk, these patients are actually those patients who should go to the cath lab within 24 hours, and these are the intermediate patients who should be done within 72 hours, 48 to 72 hours. So okay, and these are the low risk patients. So these patients shouldn't be gone to the like cath lab, but these patients should send to sent to non-invasive investigations. Got it? So these are the immediate invasive patients, these are the early invasive patients, and these are the delayed invasive patients. Now we will discuss it later on, that what are the things which actually make these patients to be in these groups, okay. So delayed invasive and low risk patients, okay. These are the ischemia guided group. This is the delayed invasive group, early invasive group, and immediate invasive group, okay. So the patient who has ongoing chest pain, persistent chest pain, irrespective of refractory to medical therapy, obviously the high risk, VT and VF, okay. Sustained ventricular tachycardia or ventricular fibrillation is a sign of that patient is a high risk, and he or she should go for immediate invasive strategy. The third thing is the hemodynamical instability. Obviously, as we discussed, that you will do all the examinations. If you are finding the hemodynamic instability with the like other things like chest pain, all these things, then in your ACS patient, obviously then your patient should go for cath immediately. And the third and the last thing is that any signs of heart failure, like pulmonary edema, S3 gallop, okay, new onset of MR. So these things actually make these patients high risk, and these patients should go for cath lab within 3 hours. And this strategy is called as immediate invasive strategy. And those patients, now you have calculated obviously the TIMI and all these things, and these, irrespective of TIMI and the Grace score, these patients should go for the cath lab. But now here the role of TIMI and Grace comes. If in the high risk patient, if your Grace is more than 140 and TIMI is more than 2, then these patients should go for early invasive. In these patients, obviously the highly trop release with the ECG changes, and these patients also should go for where for the early invasive strategy, and these patients should be done within 24 hours, and this strategy called as early invasive strategy. But delayed invasive patients are those who have a history of prior PCI, cabbage, signs of heart failures but no trop leak, okay, or like less distressed. These patients would be in less distress, would not be hemodynamical unstable, so these patients can wait till 70 hours. Or CKD, so in these patients you can wait, you have to wait till their symptoms subsides and till their or the multi-comorbid patient. But those multi-comorbs in which you are actually assuming that these patients should go for the invasive strategy rather medical therapy, okay, because most of the time if you are these non-STEMI diseases are this non-STEMI disease actually occurs in elderly population, in multi-comorbid patients, so most of the time 50% of the patient would not deserve these invasive strategies but the medical therapy. So you need to keep these things in your mind, that actually are they patient deserving to go for the cath lab or not. And the last but not the least, you have those patients who have like grace would be less than 109 and TIMI would be less than 2, like 1 or less than 1, okay, less than 1. So these patients should go for where? These patients should go for the any non-invasive investigation like CT, multi-detector CT scan or anything like stress testing. If on non-invasive investigation they would have high risk features, then again they will go for this thing, go for the early invasive. They should go for the cath lab if they would give high risk features on non-invasive investigations, okay. So this is actually excuse me, how we approach our patients in non-ST elevation MI, okay. Now we will do the immediate management, because obviously if you send only immediate invasive patients would be shifted to the cath lab from the ER, rest of the patients all would be admitted where? In ward, cath. So post cath we will discuss later on what we will do with those patients. Now we will only discuss here that immediate management in ER and then ward, okay, in ER and then ward. In ER obviously again you need to give all these things for the chest pain, nitrates, and we have already discussed the contraindication and the indication of the nitrates. So nitrates should be given to these patients. Second is morphine, and again we have discussed that Crusade trial told that liberal use of morphine gives what? Increased mortality. So you would not use liberally use the morphine, okay. Second, again oxygen, you give only oxygen to those patients who have a saturation of less than 94%, otherwise there is no need to give the oxygen. And then obviously Disprin, one adult Disprin of 326 or 4 baby aspirins, okay, of 81. Then after aspirin you will give what? P2Y12 inhibitor. We will discuss it later on tomorrow about that in which patients we would go for the which P2Y12 inhibitors, because we have again 3 options or 4 options. If this patient is going for cath lab, then again we have 2 or 3 options, and if this patient is only on medical therapy, then again we have only one clopidogrel option, so or ticagrelor. We will discuss it later on, okay, we will discuss it later on. Now assume that we are giving this patient clopidogrel because we are sending this patient to the ward. We are not discussing the patient who has been sent to the cath lab. We will discuss this patient tomorrow. And then obviously P2Y12 inhibitor. Now we have other adjunctive therapies which should be added where? In ward. So the trial which supports, one thing I forgot, in the patient, when the patient comes in the ward, then you need to calculate the bleeding scores. because now you will give what, to DAPT, obviously dual antiplatelet therapy for 1 year. It is class 1 or 2A according to the strategies of recommended by AHA and ACC. And then DAPT, obviously antithrombotic therapy. Antithrombotic therapy, you have again 3 options: unfractioned heparin, enoxaparin, and fundaprinox. All those patients who are going toward the enox and the fundaprinox are better choices, because this is twice a day and this would be a once a day. But if you are putting your patient on the unfractioned heparin, then you need to check the APTT every 6 hourly, and you have to give the unfractioned heparin in the infusion form. You cannot give the loaded like bolus doses of this unfractioned heparin to your patients. Okay, so if you are giving all these things to your patient, then you need to calculate what, the bleeding score. Now the bleeding scores you have, because you have to see your patient vigilantly, the ischemic patients, because ischemia is a two-sided, double-sided sword. Because if you are giving the blood thinners and the patient is on the high risk bleeding tendency, and if your patient has a high risk bleeding scores, then your patient can be bled anytime in the ER or in the ward, with like this patient can present to you with intracranial hemorrhages or anything like intraperitoneal hemorrhages or any life-threatening hemorrhages. So you need to calculate and you need to check the bleeding score. So now you have a 2 bleeding scores. One is a Crusade and other is Acuity. Acuity is bit difficult. Crusade is easier one, but you need to calculate this Crusade score with calculator. You cannot do it with like a bedside technique like TIMI score. Yes, we yet to discuss the TIMI score because we didn't discuss it. Yes, I will discuss here in a few minutes. Okay, so Crusade. Now what is the Crusade? The low risk, if your patient is less than 20 or 20, is a low risk score. You can easily give your patients to like dual antiplatelet with antithrombotic, and if you want to give any other antiplatelet like GP2B3 inhibitor, because there is a role of GP2B3 inhibitor on those patients who have a refractory chest pain but your cath lab is busy and your patient is actually waiting for invasive strategy. So there is a role of GP2B3 inhibitor, but this was not indicated in STEMI, but here it is indicated in non-STEMI. So it is class 2A from American College of Cardiology and American Heart Association. Yes, you can give the GP2B3 inhibitors in your patient who are actually waiting outside the cath lab for getting in for the invasive strategies. So you can give your GP2B3 inhibitor. So if your patient has a low bleeding risk score, you can use all the blood thinners on your patient, okay, according to the guidelines. But if your patient has very low, sorry, it's not low, it's very low. If it's less than 20 and if it is 21 to 30, it is low risk, and if it is 31 to 40, it is intermediate risk, and if it is more than, and if it is 41 to 50, so it is high risk, and if it is more than 50, it is very high risk. So the Crusade score tells and distribute our patients into 1, 2, 3, 4 and 5 categories. Very low risk, those patients who have a less than 20 score, it's a very low risk. You can easily and safely start all the blood thinners at your patients. And the low, and the other thing is low risk. 21 to 30 is a low risk, 31 to 40 score is intermediate, and 41 to 50 is high. And the very high, in your high and the very high patients, obviously you can use the blood thinners, but you need to be very vigilant. You need to be very careful while using all these blood thinners to your patient, because your patients are on bleeding tendency. They can bleed anytime. Okay, so you need to be very vigilant in these patients. So actually it is class 2A to calculate the bleeding score of your patients before starting the blood thinners. Most of the time we don't know that these things should be done with our patients, and then comes to beta blockers, okay, you need to start again within a 24 hours. Beta blockers trials are same. Which are the trials for atenolol? Because atenolol, you can use with normal EF, you can use any beta blocker with your patients, okay. So atenolol is ISIS 1, and again all the other trials which are with the low EF, like Comet trial and the Capricornus and the CIBIS 1, CIBIS 2, CIBIS 3, and all these trials you can quote all these trials with your patients, okay. Now we came to AC inhibitor and ARBs. So here actually it is a class 1 to start ACE inhibitor with the low EF, with the diabetes, hypertensive and stable CKD. But if none of these things are present in your patient and your patient is not hypertensive and your patient does not need to be treated for the hypertension, then this AC inhibitor in non-STEMI is class 2B. It's not class 2A. I mean, this is a very important thing, that in non-STEMI, if your patient doesn't need to be treated for the hypertension and he does not have what, low EF, diabetes, stable CKD and no other indication for the AC inhibitors, then if you are giving your patients AC inhibitor in non-ST elevation MI, then it is actually class 2B, okay. So, and the last but not the least is statins. These are the class 1 obviously in diagnosed ACCVD scores, okay, ACCVD patients. So this is a class 1 obviously. High intensity statins, you have two options. One is what, Rozua, and second is what, Atorva. Trials are same, Rozua, Jupiter and all these, Atorva, Prove It. These are the trials for these patients, okay. And now we should discuss what I haven't discussed actually P2Y12 inhibitor, which I would discuss in my next lecture, because there are a lot of things to be discussed. That's why I want to discuss it in a elaborative form, in a detailed form. So that's why I will discuss it now. TIMI, very much important, then we will sum up our lecture, okay. So TIMI, very important bedside tool to risk stratify your patient, which we have discussed, that you have to distribute or divide your patient or classify your patient into the 4 classes. So TIMI has only total 7 points and it has a separate mortality for each point. So one is age. If your age is more than 65 or equal to 65, then you will give the 1 point. Then you will give the 1 point to your patient, not equal but the more than 65, okay. Then you will give this. And if your patient has risk factors more than 3 risk factors, then, and what are those risk factors which actually come in the TIMI score? One is diabetes, 2 is hypertension, 3 is your smoking, 4 is hypolipidemia, 5 is hypercholesterolemia. It's done. Sorry. Family history, okay. These are the things which actually come into risk factors, okay. Now, if your patient has a more than 2 episode, equal or more than 2 episodes of chest pain, okay. If you're more than 2 episodes of chest pain, then it would be 1 point in 48 hours, in last 48 hours, okay. So what would be the next one? Prior coronary angiogram. If you have a prior coronary angiogram and it has more than 50% of stenosis in any of vessel, then you will give another 1 point. Leak drop is 1 point. ECG changes, ST depressions, okay. ST depressions more than 0.5, 1 point. And what would be the 7th one? Prior use of aspirin in last 7 days. So your patient have 0 or 1 score, 2 score, 3 score, 4 score, 5, 6 or 7 score, okay, and their mortality would be 4.7, 8.3, 13.2 and 19.9 and 26 and 40.9. So you can remember it like 4, 8, 14, 20, 26 and 40. 4, 8, 14, 20, 26 and 40. Sometimes they ask in our papers, even our FCBS part 2 paper, so you need to remember all these things, because this is an effective tool to risk stratify your patients on bedside. Okay, so these are actually things. Now the important thing is that your patient with the non-STEMI, most of the time they are high risk because they are elderly patients with the multi-comorbid disease. Most of the time they have the multi vessel lesions, so these are actually the high risk. Okay, I think it's enough for today, and we will inshallah do the next lecture on the rest of the treatment and the trials which actually support the medical treatment versus early invasive and versus cabbage, and all these things we will do inshallah in our next lecture. Pray for me, subscribe my channel for my future updates and my future videos, and hopefully that you will enjoy a lot and learn a lot with me, and pray for me. Thank you. Happy Ramadan.